Okay, everybody, so welcome to our second Midwife-in-Training Research and Journal Review Club in collaboration with MITRJRC. Thank you all for coming. Just want to say thank you as well for Dr. Kenwright that's joining us today to talk about perinatal mental health, and also for Jake and Heather from MITRJRC that are supporting us today as well. So if we can move to the next slide, please, Mark. So our plan for today is that we're going to have the welcome in the house rules in a moment. So for those of you that have not been to one of these sessions before, I'll give you a little bit more background around the group itself. And then we'll have some house rules and talk through some feedback that we had from the last session, which is basically the frequently asked questions. And then we're going to have our presentation and activity by Dr. Mark Kenwright, a little bit of a break in between, and then an opportunity for a Q&A at the end. Okay, so it's going to be a really interesting topic. It's something that I think as midwives we're coming into contact with more often. It's something that, as you know, I'm very passionate about as well in terms of midwifery and the links to perinatal mental health. If we can go on to the next slide, perfect. So the purpose of this club is to start getting students excited about research, to start getting you to think about research is accessible to you, that it's not just something that certain people can do or certain people can understand. So if you're a first year, then it's absolutely for you. If you're a third year, then it's absolutely for you. We all come into our roles with lots of different experience, and the ideas of this group is to start getting that conversation around research started early, so that when it does come to you actually practicing, you can link evidence-based practice with your studies, but you can also link your understanding of evidence when you become a midwife, and also hopefully get published as a student and get published as a midwife and any further training that you do. The logo that we've got there is the tree of knowledge. So it's not just what we can see at the top, it's the roots underneath it as well. So in terms of what we provide on our courses, we're hopefully providing those roots so that you can grow in your knowledge, and to see research as that key to opening up choice in our practice. So if we want to be heard in certain areas, or if there's something that you're really passionate about that you want to explore further, then doing it through research is usually the best way, because it puts us on an even level, should I say, with it being evidence-based. So that's our goals there: enhance your skills, expand your knowledge, and make an impact. And next slide, please, Mark. Just some house rules. You'll notice that your cameras and microphones are off at the moment. You will have obviously opportunities to interact when we go into the breakout rooms as well, and also to feedback. But just to say that this is a non-judgmental environment. We want you to be able to be open and discuss certain matters, and also respect each other's differences. So how you feel might not necessarily be the same as somebody else, but it's just being open to other people's ideas and views. Also within our confidentiality, we are recording today, and this will be available on a secure link. So it's just making sure that that's kept confidential. And also the NMC code, so being, you know, the 6 C's, care and compassion as well, and confidentiality. So it's adhering to those as well. When we are feeding back from the breakout rooms, we want to have that interaction, but that could be that you feel more comfortable doing that within the chat. That's okay. If you are feeling happy to contribute with your cameras on and your mic on, then that's great as well. But we want you to get the most out of it as you can. So next slide, please, Mark. So these are some of the frequently asked questions. I just wanted to go over from last time, and thank you very much for filling in those surveys, because it's really helped us to see where we can improve as well. And one of the things was, what proficiencies do the the sessions relate to. I have got another slide on that in a second, but what I would like to say is throughout your entire programme, if you look at the NMC standards, research is in every single domain of the midwifery standards, and that's what you're going into as a profession. So actually, research is embedded throughout, so you could apply it to any of those proficiencies. Hours counted for CPD, again, it's on there, so it will depend if you're on reading week at the moment or in practice. If it's in practice, it's classed as practice time. If it's in theory, it's classed as theory time. And then you also, once you fill in the survey at the end, get your certificate, which for CPD is becoming rarer and rarer to be able to get the certificates now, and that's in collaboration with MIDAs as well, so you get a nice certificate for that too from today. And just the other thing is that once you've completed the survey, the certificates will be sent out once they're completed. But if you're having any problems, let me know. And next slide, please, Mark. These are just some of the proficiencies that I would say align with this session. So if you are thinking about, oh, this could be something that I want to talk about to my practice assessor and say, we've discussed this as part of this session today, and you've got your certificate with you, you can perhaps link it to these domains. And these are sometimes difficult to actually sign off unless you've had some sort of research activity like this. So again, these are here for you to have a look at later. So I am now going to pass you over to Mark, and he's doing a session today on perinatal mental health and the breakout rooms. Mark is a mental health nurse and is Dr. Mark Kenwright, as you can see on there. So we're very lucky to have him today. And it'll be nice for you because you don't have to listen to me now. I can pass you over to Mark.
Thanks, Michelle. Thanks, everyone. Again, thanks for inviting me to speak today. So I guess the reason why I'm here talking about perinatal mental health is because my role prior to starting as senior lecturer with Staffordshire University was as clinical director for the primary care talking therapy services, which included our perinatal specialist primary care mental health service as well. And I was also previously course director for the postgraduate CBT training course. So yeah, the issues around perinatal mental health are obviously massive and really important. I think this is a really timely point to have this kind of discussion and this presentation, because we know that actually it's the mental health problems are the most common complication of childbearing, affecting about 1 in 4 women. And the reason why it affects 1 in 4 women in the perinatal period is because mental health problems affect 1 in 4 of us as people across the board. And what we'll particularly be talking about today are common mental health problems. And that means anxiety disorders and depression. But any mental health problems at all, the impact is really serious. Of course, we know certainly perinatal mental health problems, significant morbidity, mortality rates, mortality for both the fetus, the infant as well, and the mother. So really, serious consequences if these problems go unaddressed. Now, we know that for the common mental health problems, yes, around 17% of women will experience depression in the perinatal period, and it's somewhere between 15 to 20%, depending on which study you look at, for an anxiety disorder of any description. Now, thankfully, for severe mental illness, which means psychosis, symptoms of psychosis, or bipolar depression, where women will have hypomanic episodes as well as depressive episodes, the prevalence for severe mental illness is significantly less, and we're looking at around 1-2% of the population. But the impact when somebody experiences severe and lives with severe mental illness, of course, is massive. And we know that the risk period for severe mental illness is highest in the early postnatal period. So you will have heard of postpartum psychosis or puerperal psychosis for women, and that is really obviously really serious, that when women, usually within the first 2 weeks of childbirth, start to experience severe symptoms of psychosis. The reasons and the cause for it can happen within women, in women who've had no previous history of severe and enduring mental illness. So those reasons, those causes are yet unknown, essentially. Of course, hormones will play a big factor in that, potentially trauma, but really causes unknown. What we do know is that if a woman has experienced any severe mental illness at any point in her life, there's 20% of women will experience a relapse of those symptoms during that early postnatal period. So that's something to be particularly aware of and to assess for. So the commitments and the strategy for supporting perinatal mental health are really set out within the long-term plan, the NHS long-term plan, were a commitment to improve and transform mental health services. Is set out there to increase funding by £2.3 billion every year just for mental health services, to increase access to mental health services, and for perinatal mental health services, the specifics really are set out within the mental health implementation plan. So there are links on the slides to both of those and in the references, but in particular, a target and a goal to increase the length of time for which perinatal mental health support is provided for women from the 1 year that it has been currently up to 2 years. So 2 years postnatal. So for that support to increase longer term, also to increase the access to the evidence-based talking therapies, psychological therapies for both women and their partners. And that includes assessing women's partners if they access perinatal mental health services, if they're being supported, then to build in as standard an assessment for their partner's mental health as well, to look at the relationship, the quality of the relationship, and have that kind of holistic approach there, and signpost and offer support as required. So those are some of the specific commitments that are set out. Now, for the perinatal mental health services, this means establishing those services within the community, within primary care, across every NHS area in England. There are now 19 specialist mother and baby units, so one for every sort of basically every area, but there are more are needed. And then in particular, to make it easier for women to access the evidence-based talking therapies closer to home in a convenient way for them. And that will be made easier through developing the maternity outreach clinics, in line with the maternity transformation program. So the idea is that these talking therapies and psychological therapies can be offered as part of those outreach clinics and part of those teams. It means integrated care, which is something I'll go on and say a little bit more about in a minute. It means also offering the NICE guideline recommended psychological therapies, in particular for the common mental health problems, anxiety disorders and depression, offering those therapies in line with NICE recommendations, which I'll talk about in a second. And delivering that in conjunction with the existing NHS Talking Therapies programme. So this is what I used to lead, and it's been running now for 13, 14 years, and it's taken up a lot of my career. I started off leading as clinical lead for one of the first sort of demonstration sites in London, and then moved to Staffordshire and expanded the Talking Therapies programme for Staffordshire. It used to be called Improving Access to Psychological Therapies Programme, or IAPT for short. We love an acronym in the NHS, and thankfully is now just called NHS Talking Therapies, which is a lot better. We never used the term IAPT, and sort of with people, with patients, with our clients, whatever we call service users. We actually branded it as the well-being service because IAPT was just, nobody knew what that meant. But talking therapy is a lot better. So that's the new term. So these therapies for women within the perinatal period are to be delivered within the NHS Talking Therapies programme. And that programme is very much NICE guideline delivered and overseen by the NICE guidelines and the evidence base. So we have the specific NICE guidelines for antenatal and postnatal mental health. And they set out guidance for, certainly for common mental health problems, that that the therapies, the talking therapies and psychological interventions should be delivered in what's known as a stepped care model. And what we mean by that, what's meant by stepped care, is simply offering the least intensive, least intrusive, easiest to use, I suppose, most convenient type of support first. Certainly for women whose depression or anxiety symptoms are within the mild to moderate range. So if that's the case, then the idea is to offer the least intensive support first and then increase the intensity of that support as required. So the idea is it's meant to be self-correcting is the term that's used. Now, what we end up with, and what you will may have heard already, is the term low intensity interventions or low intensity treatment and high intensity treatment. Now, these terms originally were only meant to be used as management terms to refer to the intensity of the resource that we offer. There was how much it costs, basically. They were never meant originally to be used to refer to the treatments that are offered. Over the years, it's become a shorthand and has become become common parlance, really, to say low intensity treatment, high intensity treatment. We would never use those terms, and I would recommend never using those terms with women or their partners who have mental health problems, because you hear low intensity, you just hear low quality. So the idea of the lower intensity of resource is that these treatments tend to be offered by the psychological wellbeing practitioners, who are usually psychology graduates who've had 1 year specialist training, and they specialize in supporting programs like guided self-help programs for anxiety and depression. And so that's a specialist role, but they are cheaper. They're on a lower band 5, whereas therapists, say cognitive behavioral therapists or other types of therapists, will be a higher band, and their sessions are longer and take more time, and therefore it's more costly. So that's the idea of the stepped care model, is start with the easier thing to access and step up as appropriate. Now, the type of treatments and therapies that NICE recommend for anxiety disorders, for all anxiety disorders, is only cognitive behavioral therapy. So that's the case for all anxiety disorders. NICE do not recommend any other psychological therapy or talking therapy if an anxiety disorder is a woman's main problem. So that's very prescriptive. So there isn't really a choice there. However, there is a choice in how they might be able to access that, and they can access a more convenient package, such as the self-help package. It could be something online or a specialist workbook where they would have weekly appointments with their wellbeing practitioner, online or telephone. So only CBT for anxiety disorders, and that's because randomized controlled trial evidence demonstrates it to be the only approach that delivers lasting improvement for anxiety disorders. But for depression, there is a choice of talking therapies. So the evidence demonstrates that a range of therapies can be effective for depression, and so that really is up to that person's choice, whatever a woman would prefer. type of way of working that fits for her. And so cognitive behavioral therapy is still in there as one of the main evidence-based treatments, but there's also person-centered counselling. There is what's known as interpersonal therapy, which focuses on your relationships, any conflict within relationships, improving, expanding on relationships for support. So if there's a problem within relationships, then interpersonal therapy is very effective. There's also short-term psychodynamic therapy, and a range of others such as behavioural activation, which is the behavioural part of CBT, which is largely about rescheduling, restarting activities that people just stop doing because of depression. So a whole choice for depression, but for anxiety disorders only CBT. So the low intensity tends to be sort of 6 to 8 sessions, guided self-help with a wellbeing practitioner. Moving up to high intensity therapies tend to be around 12 to 18 sessions with a therapist. And the principles of care are, of course, early screening, early identification. So the idea is that we're picking up on any mental health problems at the first appointment, perhaps with a midwife, or the first postnatal visit with a health visitor. Regardless of this principle of stepped care, of starting with the least intensive first, actually the treatment is of course offered in line with a woman's preference for, across those. So this choice is really important. There's no point in sort of forcing anybody to accept or start with a guided self-help program if actually they really want to talk to a therapist, in therapy sessions. And then the other principle, of course, is integrated care, that when it's delivered, that a woman's experience should be, if she's seeing any midwife, health visitor, any health professional for her perinatal care, that if she is experiencing mental health problems as well, that her experience should be that she is simply booked into an appointment with somebody, a specialist within the same team. That should be how it feels for her. That so if she's talking to, for example, a midwife, the experience should not be that the midwife says, well, I'm assessing you for your mental health. Oh, it seems like you have a mental health problem. I'll refer you to a separate specialist mental health service over there. And they're the mental health team, and they'll send you an appointment. And because we know that for mental health, there is a massive stigma. So massive stigma for mental health, and women are particularly anxious. Of course, when you have a baby that now you're saying I have a mental health problem, you're referring me to mental health services, they get particularly anxious about what that means, and will I be assessed for my ability to look after my baby, will social services be contacted, etc. So all of those sorts of fears. So it's really important that we can say to them, okay, I can book you in for an appointment with one of our perinatal mental health wellbeing specialists, as though they are part of our team, because we all work within one integrated care team, and I can just book you in with them, or you can ring them yourself. And there's a website there for you to book an appointment. You can do that yourself if you like. It's fine. We're all part of the same team. It's not a big deal, but I can book you in for an appointment if you like. We can do that now. So it's made very easy, non-stigmatizing, and the idea is it feels integrated, like one team wrapping around a woman's care. We are holistic, and we of course care for your physical needs and babies and your emotional well-being as well. It's all of those things, so it's not a separate thing that we're referring you to for your mental health. So those are the principles, nice guidelines. CBT is a big part of course, for common mental health problems. Now, our experiences in delivering a specialist perinatal mental health service within primary care So just in GP practices, healthcare clinics, normal sort of buildings that are not separate mental health buildings, having our therapists and practitioners integrated with, working with midwives and particularly with health visitors in primary care. The experience we've had is very positive, and it's been a success as a pilot. The therapists were specialist perinatal therapists, and that meant that as well as receiving supervision in their therapy, they also received specialist training and supervision from perinatal mental health specialists, and they were with the mother and baby unit, and that supervision was ongoing. The psychological well-being practitioners who delivered the low intensity, the sort of guided self-help packages. For example, there was a specialist self-help package on overcoming postnatal depression instead of overcoming depression, which would be used widely across the service. So it was a specialist self-help package for postnatal depression. Those PWPs, as they're known for short, they will be supervised by the perinatal therapists as well. So the key principles are of course that women coming to this service, as soon as it's identified that they're struggling in any way with their mental health, either during pregnancy or postnatal, that they have a rapid appointment. So appointment slots were kept open, kept free, specifically for perinatal. We were not allowed to book into them, so that women could be booked in quickly and have an appointment within 2 weeks, no longer than 2 weeks, and then start treatment the following week. So there was no hidden wait, where we're saying, right now you've had your assessment, I'll book you in for an appointment, and that will be within so many weeks to start treatment. Treatment started immediately. And of course, the principles were that any referral, the pathways into the service were very, very flexible. So any woman can self-refer anyway and doesn't need to speak to any kind of professional to access our service. So therefore, promoting the service, having the leaflets everywhere in the waiting areas of all, of any clinics at all was really important. But of course, the midwives, the health visitors, practice nurses, anybody could also book in an appointment very easily. And that is the integrated care. Now, the outcomes from the service were very positive, and outcomes from the perinatal mental health service were just as good as the outcomes across the service generally, which were that over 70% of women demonstrated reliable improvement in the clinical measures, and they complete those clinical measures, these brief questionnaires for symptoms of depression and symptoms of anxiety, at every session. So there is a bit of a burden of that and data. They complete those questionnaires at every session, and that's used to monitor really whether they're improving or not, for them to say whether they feel there's improvement or not. So over 50% achieved what's known as reliable recovery, and that means that they have to be in recovery, so below the clinical cutoff score. Their scores have to have dropped to the recovery range for both symptoms of depression and symptoms of anxiety. They can't have either. And so over 50% achieved that recovery, and that's the target for the Talking Therapies program. But to achieve it, greater flexibility, of course, was required, and treatment duration and contact with the service tended to be longer in the perinatal period, because of course there would often be a big break during treatment, where they would have the baby and then possibly restart after that during the postnatal period. So whilst we've spoken about stepped care generally moving from things like guided self-help to stepping up to high intensity if they need that, within the postnatal within the perinatal mental health service, they would often perhaps start with high intensity, seeing a therapist, working intensively for some sessions, then have a break, and then they could be offered the self-help package and support temporarily, during that break, or during the postnatal period, so they had something postnatally to work on and support them, and then they may restart sessions with their therapist later. So there was more flexibility there. We did experience some barriers in with the integration. Some of the barriers were so the therapist would deliver training sessions, training on the service and on recognizing mental health problems, and the range of training sessions designed for different professionals to be really helpful for them. With the midwives, the barrier was getting in there, the time and the resources, because they were, basically understaffed, didn't have the resources, and it was difficult therefore for them to make the time to attend the training and teaching sessions that we could put on. With the health visitors, there was a similar barrier, but in organising training, but also some defensiveness, because one of the things that we weren't so aware of and that was surprising was how defensive they were about this new service coming in with specialist therapists for women's mental health, because of course this was part of the health visitors role, so they felt threatened by that to a degree, and they were already delivering listening visits. One of the health visitors was the lead for mental health. So there was a lot of work to do to help them to see how this service was complementary to what they were already doing and worked in conjunction with what they were already doing, and that did help to break down those barriers. And one of the biggest barriers, of course, is the bloody IT systems, just different separate IT systems. Of course, all the midwives are putting the clinical notes on one system within the hospital, and then the professionals out in the community and primary care are using a different system. The talking therapy service has its own clinical system specifically for all of its data and its outcomes. So in order to achieve real integration and working, then people needed access to multiple systems and had to have multiple logins, and that's an ongoing problem for any service and for any integration within the NHS, unfortunately. So that's a bit about the guidance, the evidence, and our experiences of delivering this kind of service. What I've put on and suggested is an interesting paper for you to look at, an interesting study. It's a mixed method study that's looking at midwives' experiences of supporting women's mental health. Now, this is part of a larger study, the Mother's Mood study, and that also looked at the experiences of mums with mental health problems, their experiences of accessing support, etc. And so part of it was looking at the mother's experiences, and part of it looking at professionals' experiences, midwives. This study by Nicola Savory and her colleagues at Cardiff University is just looking at midwives' experiences. So 145 midwives completed self-report questionnaires about answering questions about their experiences of supporting mental health, the training that they've had in supporting women with mental health problems. So there's sort of some categorical data there, some numerical kind of percentages, what percentage have had training, etc. And then there's qualitative information and data there. So 15 of the midwives attended one of 3 focus groups where they were given prompts for discussion about supporting mental health and the mental health of their women, and how did they feel about that? How did they, what kind of training have they had? How do they feel about their confidence in supporting it, etc. The facilities and resources available. So their views on the realities of trying to support women with perinatal mental health problems. And so there are lots of quotes there and sort of themes, I suppose, for that sum up their experiences. And so I thought that would be a really useful paper to look at and for you to discuss. So what we're going to do is move into breakout rooms. And I'd like you to have a look at the paper. It's been circulated and it's in the chat. And just have a skim of the paper. If you've not had a chance to look at it yet, then please sort of skim read. In particular, I'd like you to look at on page 3. It breaks down the sort of information on training that the midwives have had, what percentage have had training on mental health and recognizing mental health problems, as well as the percentages that say that they are supporting women with mental health problems. So have a look at that in the 4th paragraph of page 3. What do you think about the training that they've had in mental health and what they say about that? Just really to prompt discussions within yourselves as midwifery students. What do you think about the amount of training on perinatal mental health that you've received so far? What more would you like? How could this be improved? So that's one area for discussion. And then the second is to look on page 4 and 5. You will see lots of these quotes, the views expressed by midwives around supporting mental health, and just for you to discuss those. Do any of those views chime with yours? Do you agree with any of them or share them? Do you disagree with any of them? Have you heard others express similar views? What are your views, basically, on what you need as midwives to, to adequately, safely recognise and support the mental health of the women that you're caring for, and their partners as well? So you'll then be brought back to the main room after 15 minutes, and there will be a chance for you to feedback, sort of about 5 minutes per group for key points. So if I'll go back to that slide so you can see the discussion points we'd like you to focus on. But if somebody could be a bit of a scribe maybe and just jot down the main points that you want to feedback, that would be great.
Just thank you so much. It was really useful. I think perinatal mental health is really, really important. And there was things that I've been writing down going through as well around training, that we probably should be doing more. And also within the NMC proficiencies, pulling those out, the ones that are perinatal mental health. We have got a little bit more in our new curriculum for midwifery, but I think there's lots more that we could do. And like I say, I've written loads of things down, like IAPT. I didn't know that there was a change in name for IAPT, for instance. And I think that the fact of the low intensity treatment, it's really important to understand where that's come from, the wording. So yeah, really, really interesting. And I think we might have to still mark a few more times, I think, for some more sessions. But no, thank you very much. Really interesting. And I think people have got a lot out of it today. So thank you.
Right. Thanks all. See you again soon. Bye.